Melissa, thank you very much for coming on my podcast.
Thank you for having me.
Sure thing. So you're a pain scientist. I've read a lot of your papers about pain in the brain, and I think that they're incredibly fascinating. And I thank you for the work that you're doing. I think it's super valuable and helpful and fascinating. And I'd like to start off by having you tell us, how did you get into this field, and tell us about your background.
Oh, whoa. Okay. So I fell in love with research in undergrad. I was in a female sexual psychophysiology laboratory, and I loved, so from mind body from the very beginning. I thought I was going to continue with that, so I went to McGill to work with Irv Binnick and Jeff Mogul, who were pain guys. But I went at it sort of a sexual pain perspective approach. And while I was there, I did some animal research, developing an animal model of recurrent yeast infections while getting clinical training in sex therapy and chronic pain management using mindfulness and CBT. So it was nice because I could see what could be modeled in an animal and what was just sort of a clinical reality that we couldn't capture with the science. But it was a really rich intellectual environment that was multidisciplinary at McGill. So basic scientists went to clinical rounds. I got to hear really smart people talk and say really smart things. And working at a multidisciplinary pain clinic helped me understand how different members of a team from different perspectives, so anesthesiologists, rheumatologists, psychologists, dentists, psychiatrists, physiotherapists, how they all can work together on the same patients. And I got to hear them reason through these problems. And we saw a lot of really strange, so it was a tertiary center. We saw really strange cases. And it was so much more fascinating than sex that I decided I was a chronic pain person. My dissertation work delved a lot into the peripheral changes of nociceptors with repeated infection. And what I wanted to understand was everything from the nociceptor all the way to the brain. So I did my postdoc work with Vanya Apkarian at Northwestern University. Because I was very drawn in by the sort of the emotional basis of chronic pain. It resonated with a lot of the knowledge that I had about emotional learning in general prior to that.
Right.
Yeah.
So you started off looking at pain from the perspective of what's going on in the periphery, what's going on in the area where something's really hurting, and then you ended up focusing more on what's going on in the brain, which ultimately is processing the information from that area.
Mm-hmm.
Okay. So you've got this great quote at the start of one of your papers. I think it's called "In Search for Pelvic Pain," where you're talking about the experience of a woman that's got pelvic pain, and she goes to she might end up going to like 5 different specialists, like a urologist and a neurologist, and a physical therapist and a gynecologist. And each one of them are looking right in the area where things hurt and trying to explain the pain in relation to what's going on in the periphery there. And they're really kind of siloed. Everyone's looking at it under their own microscope. And it's kind of like the 5 blind men looking at the elephant and each saying something different. And I think your idea is that if we learn more about pain science in general, that's kind of a way to get these different people to communicate with each other, help the patient more, and see like more of the elephant.
Absolutely. Because everyone sees a problem according to their training. Physical therapists, I think, by the way, are less guilty of this than many other people because you have to naturally be like a psychologist or massage therapist also. It's I think people who work with patients who are out in the world maybe have a different sort of have to serve multiple perspectives on this. But in general, that patient was, I think we've all seen that patient, someone like that patient who has pain in a specific part of their body. And the issue is that there are no pain specialists that are well integrated into the healthcare system. And I think that this goes back to just a lack of pain education in general, like proper pain education, even within the medical system, within the US and Canada and Europe, at least that I'm aware of. A lot of the concepts that have been around for years aren't making it into basic education. And so these are things, you know, pain, wherever it is, these basic concepts aren't permeating all of these silos because they are not specific to the body region. One of the things about pain science that it took a while to learn for me was that to understand, you know, the cascade from like acute all the way to chronic, understanding what happens at the neuron level, and then the spinal cord, and then the brain, and then the neural network, and then how that sort of feedback loop you know, interacts with movement and experience over time. People go through a lot of education to learn levels of that. And what you see even in pain science literature is people specializing in the spinal cord. So even their papers are—
There's so much to know just about one
Yeah.
small little thing. It's asking a lot to ask people to know about all of them and put it together into a meaningful picture.
And it's hard to think across the levels too. Like I still can't totally get molecular. I can get some things, but it took me forever to understand what a signal was.
Uh-huh.
So it also requires a certain amount of mental flexibility that you have to practice.
And then it involves mind-body stuff, which is inherently confusing to people, and it raises philosophical questions. And once you get into that, you can go anywhere, as we know from Facebook. But let's start off. You talked about levels. Let's start off just a little bit at the kind of peripheral level, the tissue-based level. Can you just explain for the people that aren't familiar that much with pain science why pain is not the same thing as tissue damage, why you can have like a herniated disc maybe and not have pain, or why you could have a lot of pain in an area where there's not an obvious tissue-based pathology?
I mean, that's a big question. One of the simplest ways to go about that is that there are multiple— we have to kind of talk about acute pain and chronic pain differently. So even just acute pain, there are many physiological steps that occur before perception happens. And many things nociceptive events never even make their way into our consciousness. So for instance, right now, if I'm like shifting in my seat, one of the reasons why I'm doing that is that nociceptors are, you know, if I were to anthropomorphize them, they're sort of informing my body that I need to shift, not stay in any one position. Otherwise, you know, you could get bed sores or a bruise from, you know, pushing against something I mean, there's just an inherent need for the ability to adapt to an environment and not maintain the same— I'm getting a little abstract here, but
you need to protect yourself from sitting in the same part of your butt too long.
Okay, yeah, or you could go there, or you could be all practical or whatever. So even if, so for instance, one of my favorite examples of this is that A beta fiber mediated anti-nociception. So rubbing your skin lightly like this stimulates A beta fibers. Something that does immediately is that stimulation signals interneurons in the spinal cord that inhibit transmission of nociception from that same area.
That's why we rub it. That's why we rub an owie after we get hurt.
Yeah, exactly. You know, you rub it really quickly, and that's even before it gets to the brain. So there are sort of innocuous events like that can happen. Also, inflammation, which is something everyone really loves to talk about, has a lot of different time scales for different elements of it. So, for instance, with infections, peak burden, usually peak burden of a bacteria or a fungus or virus occurs maybe 2 to 3 days before peak symptoms occur. So there's also sort of this delay in the symptom expression compared to what caused it. And that's because inflammation takes, you know, a bit of time to mount. It depends on what kind of inflammation it is. But even, you know, scratching my skin like that, if I were to do this over 3 days, I would get the same type of nerve sprouting that I got in my mouse recurrent infection model. So even just mechanical stimulation, too much of it can trigger, some of these responses.
So inflammation in the periphery can kind of change quite a lot over time, and sometimes in ways it's not that predictable.
Yeah, and yeah.
I mean, that might be a reason why your pain kind of comes and goes at one time or another. You kind of have pain in the morning, but not at night, because inflammation levels are kind of this complex shifting thing that can change.
Absolutely. One of my favorite examples of that is TRPV1 receptors, which I love. TRPV1 receptors or capsaicin receptors transmit sensation signals that we interpret as painfully hot. And it was maybe just like 5 years ago that I read this. So there's still so much, there's a lot of pain science to take in. But I read that I finally realized that the acidity level of tissue affects at what temperature TRPV1 receptors activate. So if you have very acidic tissue, for example, very acidic mouth or vaginal mucosa, so I read about this in the context of mucosa, TRPV1 receptors can activate at room temperature. So you don't need 48 degrees Celsius to trigger a pain response.
Is that why some people can eat spicy food and some people can't?
That's one of the reasons. There are lots of, that's one reason. There are lots of crazy interactions. The capsaicin receptor is very interesting because it changes the behavior of receptors right around it. And it has some very interesting interactions with the receptors for touch and pain pressure. So one of my other favorite receptors.
Right? Yeah. So, I mean, we tend to think that what's going on.
Nociceptor. Just by the way, real pain scientists do sometimes say pain receptor, because if you say nociceptor all the time, it takes forever.
Yeah, I got no problem with that. I think that
it's a fact.
I'm okay.
I appreciate the noble desire to keep communication pure.
Yeah, Melzack did say that it was an unfortunate blah 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 blah, but pain receptors, come on, those are pain receptors. That's a fair description sometimes. But what's going on there is kind of like, I tend to think of what's happening in the periphery as like a simple reflexive type thing, at least in comparison to all the processing that goes on in the brain, which is so complex. But even what's going on in the periphery is so complex, it's just mind blowing. And I've heard that, and explain this to me a little bit, that nociceptors, even though I think of them as just like these little reflexive things, they can almost like learn from stimuli that's happened in the past and have like a memory. Is that right?
Yeah. Hyperalgesic priming. Ted Price does some really interesting work on that. Ted Price is a great person to look up in general. But so one way to think about that is the different forms of memory that our cells are capable of. Hyperalgesic priming is something that can be, for the sake of this conversation, can be paralleled with summation. Summation is a type of response that certain neurons show whenever there's a repeated stimulus, often at a very periodic, like maybe every 2 to 5 seconds, you have some sort of stimulus that's sort of priming, like pumping up those action potentials. And certain parts of the nervous system, like nociceptors, whenever those conditions are met, start to just sort of amplify the magnitude of that signal.
So it's like a Chinese water torture type of a situation, something that's not that bad, and in 1 or 2, stimuli. After a while, the system's just kind of like gets very reactive to it.
Yeah, and that's one of the fun secrets about central sensitization. I know we're not there yet, but
let's go ahead. We're going to move on to the spinal cord. Take us to the spinal cord.
One of my favorite factoids about central sensitization is, if you want to, the most effective way to induce it is to stimulate, I prefer heat, but there are arguments for C fiber mediated. So C fiber nociceptors are thought to predominantly mediate heat pain, although there are some nuances about that. It depends on which part of the heat pain, or A delta. But one of the most effective ways to induce central sensitization is, for example, heat pain administered every 2 seconds, moderate intensity, not high intensity, let's say 5 to 6 out of 10, for, with 2-second breaks between each stimulus. You do that.
Can you define central sensitization for us? And I know you define it very precisely.
Oh, yes. Central sensitization is a unique change that happens in spinal cord neurons. So my definition is based on the original physiological definition by Clifford Wolff, and it's been bastardized over the years, in my perception, because of lack of understanding of the ideas. But the thing itself, if you stick with the simplest idea that's been shown physiologically to be true and repeatable and generalizable over 25 plus years, it's the behavior of interneurons in the dorsal horn of the spinal cord that respond in a few ways. So the magnitude of their discharge increases over time. The duration of you could call it a discharge rate, the spike rate, if you're talking about neuron activity specifically, but the magnitude increases. The amount of stimulus required to get to, okay, let me go back for a second. The first part is the amount of stimulus required to activate the neurons is reduced. So you don't need that much of a stimulus to evoke it.
So you can have a small little insult and a lot of pain because of this.
Yeah. So that refers to allodynia. Allodynia is not specific to central sensitization, but that is a symptom that is consistent with it. Allodynia can also be purely peripherally mediated. It can also, some data suggests, could be mediated by changes in, for instance, the brainstem. So each of, anyway. Then there's the magnitude of firing in the neurons is amplified. So that, if you were to choose a sort of a correlate, would be similar to hyperalgesia. Although again, hyperalgesia is something that can be caused by the periphery or the spinal cord or contributed to by the brain. And then the final thing is that after it has discharged, you'll see repeated discharges depending on the stimulus over minutes to hours. And that's what's responsible for the after sensation. So anyone who has, so for instance, pain that lasts, one of the easiest examples for me is based on one of the populations I've worked with, women with vulvodynia, who following repeated stimulation through intercourse, so 2 to 5 seconds entry, repeated over time, against nerve fibers that are TRPV1 sensitive and C fiber dominant mediated. It's a sensation that's primarily mediated by that. They might have pain for minutes to hours to days afterward. And you see variations of this across different pain populations. One of the other things that is often confused with central sensitization is neuropathic pain. Neuropathic pain does not need to be linked with central sensitization.
Can you define neuropathic pain for us?
Dude, it's, well, after 2011. Before 2011, it was any pain I don't understand. And after 2011, a committee met and they said that you need some hardcore evidence of lesion in the.
So an injury to the nerve itself, or the maybe the sheath of the nerve.
Yeah.
Okay. So and so what
confuses, because in the animal literature, one of the easiest ways to induce central sensitization in a more chronic way is through a neuropathic pain model. So that's why they're often confused.
Okay, and but according to your view, you could induce central sensitization at the dorsal horn with any kind of repeated and maybe even better intermittent moderate nociception. That could
Yes.
be from a neuropathic lesion or something else. So, but sometimes people use central sensitization to refer to a much broader class of sensitivity. Tell us about that confusion.
That confusion, I think it's well-meaning. It's a lack of an understanding of the core idea that the phenomena was originally demonstrated in the spinal cord only. What I've thought about this a lot, and what I think happened, there were a few people that, and I won't name names, although I'd love to. There were a few people that misinterpreted this and published reviews that were widely cited and sort of read as as truth afterward. But more than that, I think that the basic scientists we didn't do our job in properly communicating what central sensitization was. And that if you look even in Clifford Wolf's papers, review papers, maybe late 2000s, early, like 2000, before 2011, he started to be careful after that. Before then, if you look at the criteria, you'd see like 3 different criteria, so some sort of allodynia, hyperalgesia, and after sensation. And it doesn't specify that it has to be all 3. In that you can have other mechanisms explain variations of those 3 things, but true central sensitization, you need sort of the trifecta. And so that's something I don't think that basic pain scientists have done a very good job at expressing.
So
that it's not just allodynia. Okay, first, allodynia can be a symptom of many things, but it isn't just this certain type of allodynia. It isn't just this certain type of hyperalgesia. It isn't just after sensation. You can mix and match between those. No, it's all 3.
So if I'm understanding you right, you're saying that central sensitization is something that happens at the dorsal horn, but you could have other forms of sensitization which happen further up the chain in the brain. We don't call that central sensitization, because when we say central sensitization, we really should be, so we don't get confused, let's just talk about the dorsal horn. And those other kinds of sensitization do exist, and they are kind of more in the center, but we shouldn't use that term because it's confusing.
Yes, yes.
That's the idea.
Yes, you can't freely generalize behavior of spinal cord neurons to the brain. Like
Right.
you just can't. For instance, there isn't is developed of a, so for instance, in the brain, the correlate would be fear learning. So that's AMPA and NMDA receptor-mediated synaptic strengthening and potentiation that are needed to form a long-term memory. And that doesn't happen. Yves de Koninck made an argument a few years ago for something like that in the spinal cord, but I didn't find it convincing.
Okay. So let's move up to the brain. And you mentioned fear learning. One of the things that I loved about your research is that, well, let's first of all, let's get to the idea of finding a pain signature in the brain. So part of the research that you've been involved in is putting people in the fMRI and seeing if you can look at the patterns and find out, is there some pattern there which can tell us that the person's in pain, or if they're in pain, can we expect to see that pattern? That's a pain signature. Am I getting that right? Explain that to me.
Yes, you're getting it right. It is a view that it comes from these old ideas that there are specific brain regions that mediate specific parts of the experience, and that you
any conscious experience.
Yeah, and that you could like statistically pull out the contribution of any of those areas. And the fact of the matter is if you have a single brain region, if it doesn't have a brain around it, it isn't going to do anything. The whole purpose of, I think that there's a benefit to the pain matrix, pain signature idea, but the benefit is that it's showing that each of these pieces need other parts in order to function. So it's the difference between a brain, a view of the brain as like these specific regions mediate these specific properties versus this group of regions work together to create a conscious experience, and
Yeah.
they each contribute different elements of it. um there are a lot of, and there's still, this is something that is still in this particular area. The sides are currently defined by Gian Domenico Ionetti, who's sort of like the anti-matrix view. And then there's Tor Wager, who's really taken his neurologic pain signature as far as he can go, and try to generalize it statistically as a map that you can use to determine whether or not someone is in pain or not. And it's based on acute pain. It isn't generalizable to chronic conditions.
So why isn't this pretty easy to test? I mean, if this Iannetti and what's his other guy, if they wanted to have a wager, it'd say put someone in an MRI, and can you accurately guess whether that guy's in pain because of the way his MRI looks? Isn't that kind of an easy argument to resolve?
No, it's not. So what it requires is a lot of statistical sophistication. So Vanya, and I believe this paper that's coming out is being led by Andrew Vygotsky, who he works with Upcarrion right now. He's switched over from more of a kinesiology perspective, muscle physiology sort of perspective to brain imaging. And some of the computations that he's done are quite sophisticated and show the amount of what so this is something that will be published within the next year, I believe. And what it shows really clearly is that the statistical assumptions behind these types of analyses are poorly understood by the people who use them. And that's like my clear as mud kind of way of explaining it, because some of the analyses get quite sophisticated. But these all have statistical assumptions that need to be examined really carefully and thoughtfully before just saying that two maps are the same thing. And also, just from a practical experience, I have some unpublished research that I've tried to do it myself. And whenever you do a really carefully controlled experiment that's what we call event related, in brain imaging, there are two different types of studies, you could say. There's like a task related, and then there's the resting state related studies.
So you put someone in an MRI, you ask them to do something, and you see what their brain does. That's the task related.
What you do is you then make a model, I think, based on what I told you to do, that I should see brain activity here, 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 and here. I'm going to make a model of that. And whatever I find at the times and places that I expect brain activity, I'm going to say that that validates my assumption, my hypothesis, which means that you're only going to find something that's as clever as the researcher, in a sense, because the researcher is projecting their expectation of reality onto the data, and they're only looking where they think they're going to find something. Resting state data is any scan where you just let people's mind wander, you don't ask them to do anything, and you can do statistical analyses between and across regions and see the dynamics a bit better. But still, you can only make these sort of vague conclusions, like this is how much these two areas communicate. And if you, for instance, correlate that with the clinical severity of pain, then you make the assumption that, that symptom that you're looking at is correlated with, that's somehow mechanistically linked, but it's an assumption.
Okay. So let's talk about, with some of these caveats in mind about the difficulty of interpreting MRI stuff. And I want to get back to that a little bit more. Tell us, what you have found working in the Upcarrion lab about, for one thing, what kind of pain signatures we can discover, and also the transition from acute to chronic pain, and whether there are brain, I don't know if the right word is signatures associated with that transition that can allow us to predict who's going to transition from acute to chronic pain?
So one of the first things that there are a few major principles I've learned. One is the value of measuring spontaneous pain. And that's pain that isn't pain that you like cause, like with a thermode, you just put it, I'm going to put this, thermode on your forearm and it's going to tell me about your back pain. That's something that most of the pain imaging field is based on whenever they look at chronic populations. One of the things that Vanya did that was really brilliant is he had a finger span device made that's just a potentiometer, a displacement potentiometer. And he'd have people, while they were laying in the scanner, sort of with their fingers indicate how little or how much pain they had. And this is calibrated to every person to where it's like 0.
How long are they in that scanner?
10 minutes.
10 minutes. Okay. So so they have enough variation to get some data.
Yeah. And so they read it second to second, moment to moment, whatever pain they have. This has been done in men with chronic pelvic pain. This has been done in men and women with low back pain. This has been done with postherpetic neuralgia. This has been done by Paul Geha with, oh my God, I can never remember it. Oh, dude, it's the one name that I always forget. It's the melalgia. Melalgia. It's one of the ones that is genetically predisposed. It's a nasty neuropathic pain condition. And also complex regional pain syndrome. So what you find is that, and any patient can tell you this, pain changes second to second, moment to moment. It's not just right now it's a 10, okay, but right now it might be different. Wait 10 minutes, it'll be something else. And what Vanya's found is that variability over time. You can sort of see it as a, or maybe from your direction, as a, a time course. You're then able to extract brain activity that goes up whenever their pain perception goes up, goes down whenever their pain perception goes down. And what you find are some similarities across chronic pain conditions, but a lot of differences. One of the things that has been most interesting over time was based on that original spontaneous pain data, and it's in people with chronic back pain. So a lot of Vanya's work has been based in people with chronic low back pain and or compared with knee osteoarthritis compared with people with CRPS. So one of the other things that he's done that's quite nice is look across populations rather than just focus on a single population for each study. And what he found in those original works was that the medial prefrontal cortex was a dominant brain region the activity always increased whenever someone's pain was increasing. And it'd go down whenever the pain.
In all three kinds of pain that he looked at, or that was common to the knee and the back and the CRPS?
That was primary to low back pain. You don't
see that pattern with the other ones?
You don't see it as clearly, no. And that you could argue with knee osteoarthritis, you could argue that these are all, for interpretation, but you could argue that there's still some incoming peripheral input, so it may not be as brain mediated as low back pain. With CRPS, there are also probably diverse vascular and nervous system changes that aren't wholly contained in the brain. So it seems to be something that's quite specific to low back pain. But the reason it's interesting is that it's the area is something that is associated with emotional learning. And so across the years, across like 15 years, in multiple studies, he came up with the same region using different methods, different approaches, different populations of people with low back pain, and it kept on coming up. And one of the reasons why I have a lot of faith in his research is that the outcome so he also did the first longitudinal study of subacute, so pain within someone's had low back pain for maybe 2-ish months, to the chronic phase. So 1 to 3 years. He followed them longitudinally. That first year, he had 6 different scans across that year of the brain. Took tons of questionnaire data too, to try to predict how could he, is there anything in the brain that could tell him who's going to have pain a year later? And what told him that, the measure that predicted that was how much the medial prefrontal cortex was communicating with the nucleus accumbens. The nucleus accumbens is involved in reward prediction, salience, and I mean, some would say sort of positive reinforcement learning. But it again highlighted that the people who transition to chronicity are the ones who there's more information being shared between sort of vaguely put, a reward region and an emotional learning region. So it's that process seems to be driven by a sort of a emotion and motivational circuit. And again, it was foreshadowed by all those studies in the 15 years prior. He didn't know what it meant then, but that's one of the really nice things that has come out of that lab. And it suggests, whenever they looked at the pattern, sort of the pain matrix signature kind of pattern over time in this population, they found that whenever people first came into the study, within the first 2 months, they saw that very acute pain typical signature. It looked like acute pain. You could compare it with someone who got a heat thermode placed on their forearm. It was the same brain signature. But over time, the people who, first of all, and this was collected with the data, the finger span data, where people weren't rating anything outside their bodies. They were just telling us how much pain they were experiencing in that moment. So it wasn't an external stimulus they were rating. It was their internal state. For the people whose pain resolved, which was about 50% of them, over time, because they aren't rating anything, they don't have pain, that map kind of disappeared. For the people whose pain continued, they saw a slow shift from those more sensory regions to emotional regions, like the amygdala, certain parts of the medial prefrontal cortex. And whenever they tracked over the same time period, people who just have chronic low back pain, sort of as an additional control group, at 1 year, the people whose pain had transitioned to chronicity, their pain looked more like chronic pain patients. So they saw in time, so how I interpret this is, whenever pain is fresh and it's, you're still working with it, it makes sense that the sensory regions of the brain are processing that information. But the sensory regions of your brain can't just do that for the rest of your life, because there are new threats that come along. You wouldn't be able to focus on new threats. And so there seems to be sort of like a passing on of responsibility to an older part of the brain, which is the subcortical sort of emotional regions. And that's why a year later, the brain areas that are active whenever someone is feeling pain in their back are emotional regions. So, that also, but prior to this, we were talking about the sensory nature of emotions. This also captures some of that, where, I'm sure many people who are watching, they have a trigger and they know how their body feels whenever they have that trigger. For me, it's like my throat tightens up and my chest tightens up. That's my anxiety response. And in that sense, for all my life, whenever I felt anxiety, I feel it in those parts of my body. It is embodied. So whether it's learned or innate, I don't know, but there is a precedent for sort of this hardwiring of emotional sensations in the body. And this is a nice snapshot of how that could evolve.
That's great. So it sounds like, to just kind of sum up, pain goes from being at the outset, at the acute stage, more of a sensory experience to more of an emotional experience, at least in terms of the parts of the brain that are governing whether that conscious perception happens. And something that I kind of noticed, kind of listening to my own body over time, was that uh, all sensations have some emotional element to them, all conscious perceptions about your body, but there's way more. And this one kind of insight I had once was that different kinds of pains that I can have, uh, a, a little bit of pain might actually be like really bad, whereas a lot of pain might not be that bad in terms of suffering. So like if I have a little pain in my neck, that's like right up in my business, and it's emotional, and it's like right in my head here, and it really bothers me. There's like an emotional feeling of fear, and how long is this going to go on, and I'm very motivated to get rid of that. Whereas if like I smacked my foot on the table and it's really intense pain, it's not necessarily that bad. It's just like, whoa, wow, that really hurts. And I'm not that, I know it's going away, and I'm not afraid of it. And so this idea that the sensory discriminative nature of pain, like how intense is it, where is different from the emotional affective. How motivated are you to get out of it, and how many feels does that give you? Those are kind of different things.
Yeah, absolutely. And a couple of things that come to mind. Um, Often things that are more centralized in the body, meaning center line, are seen as more distressing. So, for instance, people with trigeminal neuralgia or migraines. It you also, if you think about, it's you could argue it's easier to forget or to ignore or to dissociate yourself from pain in an extremity than from something that's midline. There's also some element of that is visceral pain. So somatic pain is defined as, in terms of pain science, somatic pain is pain that originates in bone, skin, or muscle, and visceral is in sort of the visceral structures. Visceral pain, by definition, according to Fernando Severa's classic work, it's always accompanied by a little bit of sympathetic arousal and negative affect. And the one of the ways that that's been explained is that if you have, first of all, it takes a bit to get visceral pain. But if you have injuries in one of your internal organs, that's probably pretty serious. So you need more motivation to protect your body, to sort of to recuperate. Whereas arguably, if you have a massive injury in your hand, you could cut it off and your organism would still live. So there's also a different emotional valence that could be linked with the importance of the body part.
You talked about the very emotional nature of pelvic pain.
Yeah.
One of your and I have that experience. I like this idea of the
Oh,
midline.
were you about to say?
Well, I mean, I like that idea about the midline. I hadn't thought about that, but that's kind of what I was saying about the neck. It's like right up here with me, and the foot, that's way down there. You know, it's almost like not me. I mean, it's bothering me, but I can ignore it a little bit. And there's some types of pains that just like nausea, a little bit of nausea to me, even if it's not that intense, that really bothers me.
Yeah. Oh, I hate nausea. But this also generalizes, though, to space around the body. And one of the really nice studies that showed this was Gian Domenico Inetti's work. I think it was like 2010 or 2011. I don't remember which, but he had people with CRPS. I'm pretty sure he blocked their vision. Each person who was in the study had an afflicted arm. Typical symptoms of CRPS, you have so a number of things. There'll be pain, exquisite allodynia. The skin will get a bluish, shiny tint. The hair will grow strong, like more. The nails will grow longer. It sweats. There are lots of sort of vascular changes that happen. But also the temperature changes. Sometimes it drops a bit. And what he did is he had people with unilateral CRPS pain, upper quadrant, without being able to see where their hands were exactly. He had them switch sides. And then he did temperature and sensory testing before and after the switch. And let's say let's say that my left arm is my CRPS arm. Whenever it moved to the right side, the temperature would slightly normalize and there'd be less sensory abnormalities, like the sensitivity would normalize a bit. And the healthy arm, the temperature would change slightly and become more sensitive. And the really like profound implication of that is that we also encode quadrants of space around our body as more or less painful. So for that person, for the person with CRPS on the left side is dangerous. They probably respond differently to threats approaching from the left side than the right side.
Awesome. I think Lorimer Moseley might have done some research on that. How consistent is the kind of general work and ideas of Lorimer Moseley with Vanya? How would you compare and contrast?
Oh, Moseley's he's a bit everywhere. He does excellent research. I think that what he focuses, I would say the difference is that Vanya's work focuses more on the person's perception of what's happening inside their body, whereas in a very general sense, Lorimer focuses more on relation of self with outside, self with external, like visual cues or sensory cues or moving in the world. Vanya doesn't do a lot of stuff incorporating movement.
Right. Well, I think when Vanya came out with that paper that was on predicting the transition from acute to chronic pain, Moseley wrote a blog post and said, what if I could have got those people at the 2 months? Could he have prevented the emotional learning that's happening with pain neuroscience education, with getting those people to maybe not catastrophize? Is there a way, since this is, in some ways a mental event that's going on, of course, it's an unconscious mental event, would there be some way to help with that so that transition doesn't occur?
So Vanya came out with a paper within the past year-ish on it's a pilot study from a small clinical trial that he was able to do. He found an answer for that's more applicable to women than men, which you could argue is great because proportion of women with chronic pain tends to be greater than that of men. But what he found was that if you get women within that first couple of months of developing back pain and you give them naproxen plus L-DOPA, for that group, there was an 80% reduction in pain and he followed them over 3 years. So that group had a really dramatic reduction in pain. Either the pain would completely go away or it'd be minimal after 6 months. And whatever change he saw was maintained. The less, so that was specific to women. And
so that didn't work in men.
His interpretation it's open for interpretation. Just generally, the mechanism was addition of naproxen reduces peripheral inflammation. One could argue that addition of L-DOPA is increasing learning that there's less inflammation in the body than there should be. That's one way of looking at it. You could also argue that women may be more predisposed to emotional learning than men, depending on how emotionally malleable they are, how emotionally. Another way of stating that whole story is people who are emotional learners are more likely to develop pain given this, right circumstances.
Can you let's talk more about emotional learning, because I've always found this phrase to be kind of confusing. Does it have some connection to kind of like a Pavlovian style of learning? So like where you start to associate one thing with another thing, like you start to learn that every time I bend over, I'm going to have back pain, and those things become very, very, very connected in your mind. Is that kind of what's meant by emotional learning?
It begins with that, but what is implied more is the suffering that comes with chronic pain is the emotional learning. AKA, yes, every time you bend over, it'll hurt. But what does that mean if you can't bend over and pick up your grandkids? You know, that means that you can't interact with your loved ones. So it's, in a sense, it's linked with all the consequences of chronic pain and the suffering that triggers and maintains over time.
So is it fair to
For
say you're starting to like build this model of the world, that it's a dangerous world and we need protection? And so the protective parts of the brain are reaching in there to protect you at all times. Kind of reminds me of like the way, like kind of like a PTSD situation, where if you go through trauma, you have learned that the world or this particular stimulus is a dangerous place, and you have this huge protective response, and there's a memory there, there's a learning that happens, and you'd really kind of like to forget or unlearn this horrible thing that you've learned about the world, but you can't.
Yeah, yeah, and there's some people with pain who will say the first 6 months of it, it was like they had PTSD. I've heard this from several patients over the years. Whenever they sort of obsess about it early on, maybe often correlated with a really stressful period at work. But they'll that's the perfect condition, sort of psychological state for long-term emotional learning. You're creating a constant fear state that's reinforcing whatever you're learning. So the
Right.
antidote to that is um, reducing anxiety, increasing parasympathetic arousal with deep breathing as much as possible, to where you aren't training your body to expect fear with every single movement.
Right. So yeah, let's get into a little bit about how we can use this this information to help people that are in chronic pain, because we know it is an incredibly challenging thing to treat. It's like kind of like using this idea of memory. I mean, it's easier to get things into your memory than to get them out. If they're really burned into your memory, how do you forget something, or how do you unlearn something? Or how do you break a connection that's been made? So what are some of the ways you go in? And I know you're interested in CBT and meditation and things like that.
One of the most beautiful things about emotional memories, which is one of the reasons why I'm incredibly optimistic about chronic pain, is that emotional memories, we know, like, what is it, 20 years now? We have 20 years of animal data telling us exactly what happens with emotional memories. And one of the beautiful things about emotional memories is that we know that by definition, they can be reactivated and fundamentally altered. And this process, if you want to look into it, is called memory reconsolidation. And the person to learn about it from is Karim Nader. He was also at McGill. Um, and the framework, the learning framework, is that if you have an emotional event, sensory, emotional, whatever you have, whenever you reactivate it, if you're able to reactivate it to as full of an extent as you're comfortable with, you have a 4-hour window where that memory becomes fundamentally labile to new learning. So if we assume that chronic pain is a fear learning phenomena that's intrinsically linked with sensation, what that means is that taking a situation whenever you know that you're about to be suffering, maybe during a flare, for example, or maybe you know how to induce the pain and you know that you're going to go into it. I've worked with patients one-on-one with this. But if you know that you're about to get to the worst of it, and you have a plan over the next, especially hour, but 4 hours, to make sure that you wind down as much as possible, if you're able to create circumstances where you're more relaxed, less fearful, and if you're able to introduce some novel element, some novel learning element that violates your expectations, that's the perfect recipe for emotional memory revision. And what will happen, as long as you end up more relaxed than you began, that memory will be re-encoded as less frightening. So you can do that over multiple sessions, with a gradual approach. You can do it in big whopping sessions. the main thing that is tricky about this is that the more you activate the memory, the more you suffer in the moment. And these are often things that people work really hard to avoid feeling. Um, so it's, you can, so there are ways to manipulate this with just both behaviorally and with the aid of medications. But behavior can work perfectly fine. For instance, deep breathing is a very effective way of activating the parasympathetic nervous system and ensuring that you are more relaxed than you began. So even if you don't do anything else, just deep breathing by itself and making sure that you don't introduce any novel, frightening, any fear elements, any more anxiety over the next 4 hours, that's your encoding window that you can ensure you've changed the fundamental structure of that memory. The thing
So,
is these memories are like webs. So you have the pain itself, but then all the things that the pain is related to, it will also dampen the memory of all of those connections of that memory. So you're working on a network of memories. It's not just the pain memory itself.
it's great. So learning got you into this, but learning can get you out as well.
Absolutely.
Yeah.
Absolutely. And it's the emotional nature of the learning that makes it susceptible to change.
Yeah. And if there's this memory, my understanding of memory is it's like every time you access that memory, you're kind of like rewriting it. And every
Yes.
and every subsequent time you have the memory, you're looking at not the original version of the writing, but that's why they kind of change. They slowly change over time, and you
Yeah,
can change the memories related to pain, slowly over time. Uh,
absolutely. And one of the tricky things with pain is that it often tags along with what in CBT or psychology is called a core belief. And um, actually, Gilletta talks about this. She's spoken about this really nicely in her blogs. Um, we all have these core beliefs that we've had since we were young, often formed within the first few years of life. And they are statements about ourselves, our worth, our lovability that are in terms a child can understand. I'm not lovable. I'm not worthy. Um, I I can never do anything right. These very simple statements where if you take any person who's depressed or anxious or catastrophizing, you can filter down the layers of thoughts to simpler and simpler and simpler thoughts. And there's always a core belief underlying it. And it's often from childhood. And it often plays a role in a lot of the conflicts that you experience throughout life. And one of the ways that it's sort of your template for why life sucks for you. And because chronic pain introduces so many different challenges, it will often piggyback on that sort of core injury, that core belief, to where, and this is something that Peter O'Sullivan gets at whenever he does his really thorough intake assessments of, what is, you, I've seen it in action, and then also how he describes it. He gets to the core belief of sort of what the person fears most is true about them. And by reactivating that part of it with the emotional memory of the pain, you then make that core belief susceptible to revision too. And that's where some magic comes in.
yeah, just for those who don't know, Gilletta Belton writes about her recovery from chronic pain, and the way she writes about it is, well, for one thing, I recommend everyone go read her blog. But there is this, I like this idea of core belief, because what she's describing that is a shift in her core belief about what her pain meant that happened, which was kind of like this, when she started going downhill towards getting better, that's when she kind of like got over the hump, was just this totally different conception of maybe if it was not being broken, or it's okay for me to go do stuff, or not, I'm not exactly sure what it was, but that seems to be what she's talking about.
And the underlying belief, underlying all core beliefs, is that somehow we're separate from love. And it's, I don't know if it's a human thing or what, but the illusion that we somehow need to do something to be loved is underlying a lot of society's fears, but also a lot of the core beliefs that feed into the chronic pain cycle. Like, this is another example of how, like, I don't deserve happiness because X, Y, Z. And it's all this core illusion that we're unlovable, that we needed to have done something to be lovable to deserve other people's love. And all the negative experiences we have throughout life that have reinforced that false narrative, that illusion, it the whole thing needs to come down eventually.
Uh-huh. Uh-huh. Yeah, that's very profound. One caveat I want to throw in here is something I kind of meant to say earlier. There's something that I always say whenever I'm talking about pain in the brain, is just because the brain has something to do with pain, it doesn't mean that you can think your pain away, or you can therapy your pain away, or that pain is your fault, or that it's not real, or that it's imagined. The parts of the brain that are involved in creating your pain are unconscious, not necessarily subject to your control, and no one should ever feel, bad or stigmatized for having the kind of brain that's better at emotional learning in regard to pain than anyone else.
The thing something I love to tell people with pain is that their bodies, their brains did everything it was supposed to do. To me, the more I got into the brain, the more I learned that, there are some people who will call it like the neuropathology, that we found was XYZ. And I don't find any pathology. What the body did is it learned a threat really effectively. And our bodies are naturally designed, I don't know, they're naturally, they naturally amp up important information to make sure that you learn it and that you act on it in the future because it protects you. So even central sensitization is your body protecting you so beautifully. Like, there's nothing that goes wrong in this process. Our brains are naturally fantastic at emotional learning, better than any other kind of learning. Adding a strong and negative or positive emotion makes a memory so much stronger. So the body and the mind are working exactly how they should. The only thing is it never went back to baseline after the threat was gone.
Right, right.
Learned so well. So there is no, so chronic pain, even if it's maintained by emotional regions in the brain, it's no more or less real than vision or taste or any other perception, sensory perception we have. It's equally as real.
Tell us about your most recent business that you're involved in that has something to do with applying these principles and helping people in pain.
Yeah. Vanya, myself, and a chronic pain patient, Mika Margalaxo, have gotten together and created Avo Health. It's in its current form, it's a smartphone app that uses mindfulness and CBT to help guide people with chronic pain through that experience. And it incorporates these sort of embodied neuroscience ideas, mindfulness meditations that I created. So this is one of the interesting things I've been getting into. So if you want, for instance, your patients to have mindfulness meditations that a neuroscientist created, this is a good thing. But right now we're going to be launching in 2 months, and it's free. We want to just see how people benefit from it, see how we can learn from the experiences of people who are suffering with actual pain. The idea is, the initial product is mindfulness-based CBT that I wrote. It'll evolve into a reinforcement learning-based program that suggests recommendations for different treatment combinations. So at the core of this is that the mind needs the body needs the mind. The mind is hungry to learn from the body what the environment is around it. And so by understanding that there'll be peripheral elements, some spinal elements, and then some sort of brain contribution to the pain experience, you then get out of this, I don't know, some of these, the thinking that there should be one drug that I finally take and my pain will go away. The fact of the matter is that if multiple parts of your nervous system are functioning in different ways, they need different parts of treatments. And so one of my biggest beliefs is that partial treatment response is fantastically important, because it can tell you, it can teach you what your body is responding to. So if you have a patient who, responds to massage or to physical therapy for a couple of days, that's fantastic. That tells you maybe, 2 or 3 out of 10 of their pain is muscle related or is tension related. And if you were to get that under control for a long enough period of time, there are other layers that can then be susceptible to other treatments. So in a sense, that we don't care what the treatment that we don't care which treatments they are. What we care is that it's matched to a person's symptoms in a way that reflects their actual experience.
Right.
So we use this by we track their pain each day, and we use analyses and methods developed in Vania's lab to identify different types of patient groups who are more likely to respond to different types of treatment combinations.
That's great.
And
Tell me about the role of mindfulness and meditation in helping with chronic pain.
That's so big. It's something, I think the word mindfulness is a bad word because a lot of people have some judgment associated with it. One of the things that I think is most important about, most useful about mindfulness is learning to not judge physical sensations or overinterpret, but also there is lots of emotional processing that occurs during motivation that can be incredibly therapeutic from a psychological perspective and a physical perspective. And not being afraid of those emotions as they happen and not being afraid of what comes up is a practice that can be learned. And that the practice is what you decide to pay attention to and what you decide to let go. So it's both inhibition of attention and focusing attention. And being able to
just give us an example of what that looks like if you're like putting non-judgmental, mindful attention on something that's going on in your body.
Sure. For example, let's say that someone has pelvic pain and which is negatively balanced, and you're asking them to lay back and deep breathe and relax. Someone who does this beautifully, by the way, is Bruno Cayun. He's a mindfulness CBT therapist in Tasmania who is fucking awesome. His work is so beautiful, so beautiful. So if you have the person relaxed and to start focusing on different elements of the sensations. So for example, what temperature is it? So just right now, everything else, let it go to the background. What temperature do you feel? If it's numb, it might have no temperature. If it's burning or electric pain, it might have very strong temperature. Okay, so, you have them focus on this one element, this one sensory element of the whole experience. Okay, then you shift their attention to movement. Is it condensed? Is it, staying in one part, or is it sort of radiating? And just focus on that radiation, just the sensation of the movement. Okay, after that, shift your focus to sort of diffuse or localizedness. Is it like sharp, pinprick in one spot, or is it diffuse and it spreads over a large part of your body? Does it even feel like it expands outside of your body?
You could just keep going with this stuff. There's a whole world of sensation that most people completely miss out on unless you even think of looking into that one little thing. So there's just a whole world of stuff that's happening. And in an area that may hurt, and if all your attention goes to the badness of the hurt,
You're missing
kind of
all.
like, but you're kind of focusing on that and kind of increasing it. Yeah.
What it does is it also gives them a real life experience of experiencing the pain in a different way that isn't emotional. It allows for that observer effect and the experience of feeling their pain in a way that it's not just neutral, it's as if it's from a different perspective. So it's the perspective taking aspect that's therapeutic, and that the worst thing you could do with a pain patient is to have them focus on exactly how they feel the pain and how bad it feels.
The badness.
Yeah. And because you get lost in that. Once you start opening up their view of different types of sensations, like the idea that there's either painful or not painful reflects a certain distortion of reality, like to begin with. And so of all the non-painful, or even of the gray area painful, what are all the sensations that lie in between? Because relief, on the way to relief, is you starting to appreciate the different levels of sensations that are just short of pain, even more short of pain. It takes practice to start to perceive your reality and your body in a way that attends to all of those nuances, because that's where relief is. Relief isn't total loss of pain. It'll happen in stages. And the more someone is able to appreciate, okay, so today my pain, I still have it, but I don't have that sharp part that I hate. Okay, this is good. I can relax into this. Because pain will shift every day and multiple times per day. So being able to appreciate that period of relief, or what relief can feel like. It isn't just presence or absence of pain, it's variations of relief. And ideally superimposing positive emotional learning on top of that also it can help retrain the brain to focus on pleasurable experiences, which aren't on your radar whenever you're just thinking about, is it painful or not painful?
Yeah. Yeah. I think that some of this stuff,
and so meditation feels great also, which is, there's also a euphoric element, even neutral is pleasurable.
Yeah. Yeah. Well, I think, where can people find you, learn more about your business, learn more about what you're up to? Twitter, websites?
Yeah. So, let's see. So, my personal website is visceralmind.science. My sort of the Avo Health website is www.avohealth.com. You can find me on Twitter. I've had a little bit of a break from social media in the past few months.
Why would you do that?
Because I'm focusing on what a positive reality could feel like. I'm creating a positive reality.
Good choice.
So it's preferential filtering of my reality. So on there, I'm Farmer _ mind body, but also I'm creating a new persona that will be coming out in the next month or two called Neurofem. So you will be able to find more free meditations on neurofem.com in the next few months.
That sounds interesting. Yeah. Anything else?
Anything else? Yeah, one of empathy. One of my recent realizations in how. So this is sort of a jump to a different direction, but if you have a negative internal state and you're looking at the potential benefit of social interaction on a person's physical pain, a person who has pretty negative emotions, one of the ways that they can get the positive emotions that they lack is through empathy with someone else who can mirror to them the emotions that they want to feel. And I have a theory about this, no data whatsoever, but I have a theory about this, that that capacity to empathize with someone else's physical state is also a way to neutralize some of the sensations in one's own body by experiencing diffuse emotions, diffuse positive emotions like compassion or gratitude. So it's purely an idea, but that's something else I want to throw out there, that I think that pain relief could be socially transmitted through empathy and interacting with someone who's of a more positive mental state than oneself.
Yeah, well, there's definitely some evidence that's consistent with that idea, and I look forward to more of the theory coming out.
Cool.
Well, thank you very much for coming on.
Thank you for having me. I'm very thankful for you.
Thanks very much.
I appreciate you so much.
Okay. Bye-bye.
Bye.
Whoops. I just meant to stop the recording.